Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh, and a very good morning to all of you, the audiences. I would like to welcome the presenters today, the staffs from the lecturers from ophthalmology department, also other departments, students, trainees, and also all students. It is now 8:03, I think. I think we should start because it's going to be 4 presenters in total, so we don't want to exceed the timing of 9 o'clock, okay, as much as possible. Okay, I would like to first introduce our CPC today, entitled When Each Turns Blinding. It is actually about a patient that we treated in our ophthalmology department, and we will receive inputs from both our invited speaker, which is Associate Professor Dr. Adawiyah Jamil, and also Associate Professor Dr. Aneeza Khairiyah. And the case will be presented by our master's student, which is Dr. Muhammad Nabil, Thaqif, Ismail. And I am Associate Professor Dr. Haslina Halim, which is the cornea consultant for HCTM. So without further ado, I would like to invite our first speaker, Dr. Muhammad Nabil Thaqif Ismail, to present regarding our case. Dr. Nabil.
Thank you, Prof. Assalamualaikum and a very good morning. Respected Chairperson, Prof. Haslina, distinguished panelists, Prof. Adawiyah, Prof. Aneeza, Senior Consultant Lecturers, colleagues and fellow students. Today I'll be presenting a case for this clinical pathological conference. So our case is a 13-year-old boy with underlying atopy, bronchial asthma, eczema, allergic rhinitis, presented with 2 weeks history of bilateral eye redness and discharge. So for the eye redness, it is persistent for the duration. It's diffused bilaterally, more prominent in the morning and upon waking up. It was associated with bilateral eye discharge with the patient described as minimal, whitish and ropey. It is also associated with itchiness to both of his eyes, and there's frequent rubbing. And upon further questioning, there's a similar episode going on for the past 2 years, which recur about once every 1 or 2 months, and it's been previously self-resolving. So there's also blurring of vision for this duration. It was gradual in onset. It affects bilateral eye, but more worse over the right eye. Generalized in nature, initially it was painless and subsequently developed slight discomfort associated with tearing and photophobia, and there's also gritty foreign body sensations. The mother brought the patient to general practitioner around 2 weeks prior to the presentation to us, and he was prescribed with Neodeca 3 times per day, which is a combination of dexamethasone and antibiotic, which is neomycin and polymyxin B. However, the symptom persists, and there is no history of trauma, no history of foreign body entered his eye, no previous sick contact with any red eye cases, there's no history of swimming, no history of using contact lens. Upon systemic review, he also complained of exercise-induced cough, blocked nose, amenorrhea, especially in the morning, frequent sneezing, itchiness of the neck and back of the knee. Otherwise, he denies episodes of wheezing. There's no history of waking up at night due to dyspnea or cough, no epistaxis, and there's no facial pain or any history. He was diagnosed with bronchial asthma by a general practitioner around at the age of 10 years old, where he had a few episodes going for nebulization. And the last nebulization was around a year ago. And previously, he was on Ventolin inhaler, which he subsequently defaulted. And usual trigger is upper respiratory tract infection and also cold. there's no proper follow-up and there is no history of hospitalization. And he also has eczema, which was diagnosed by the same GP at the age of around 7 to 8 years old. He had using topical steroid previously and currently only on aqueous cream, which he used on PRN basis. And he also has allergic rhinitis, which was diagnosed around a year ago and under ANT-HPKK follow-up, and on mometasone nasal spray 2-puff OD. And he also on loratadine 10 mg once a day. There's no past surgical history. For the birth history, antenatally uneventful. He was born full term via SVD, completed vaccination, and additionally received influenza vaccine on October 2025. No previous ocular surgery, no previous ocular trauma, no prior follow-up for any ocular diseases. He is known to be allergic to seafood, which is prawn. However, where he developed mild urticarial rashes upon ingestion, especially over the trunk and limb. However, there is no prior formal allergic test being done to confirm the allergy. No previous hospitalization due to allergy, and there's no history of anaphylaxis. And he also no known drug allergy. He is the second out of 4 siblings. Other sibling is well, there's no atopy. Mother have bronchial asthma and cousin over the paternal side have eczema. There's no family history of ocular diseases. For the social history, he lives with parents and siblings. His father is a 54 years old who worked as a cook and a non-smoker. Mother is 43 years old, housewife, and also non-smoker. They live in double-story terrace house at Ampang. There's no pet and also carpets in-house, and they use air condition in their bedroom, and he's currently attend SMK Methodist Boys School. So for the summary of the history, this is a 13 years old boy with underlying atopy presented with bilateral eye redness and discharge for 2 weeks duration, is associated with itchiness, tearing, photophobia, painless bilateral eyes, blurring of vision. So we move on to the physical examination. As you can see, on presentation, the patient's right eye vision is 6/36 without, there's no improvement on pinhole. For the left eye, the vision upon presentation is 6/18 with no pinhole on, no improvement on pinhole. You can see the photo at the center down. That's the normal tarsal conjunctiva photo. So in this photo, we can see that this is the right tarsal conjunctiva, this is the left tarsal conjunctiva. It is injected with giant cobblestone papillae. So for the interest of the medical student, the name cobblestone is basically from the cobblestone pavement. You can see the look-alike features. And there's also ropey discharge seen and also mucoid discharge. So next, the cornea examination. You can see that there's gelatinous limbal thickening, there's conjunctival hyperemia, and there's corneal epithelial defect over the right inferior temporal paracentral cornea. So on focus examination of the limbal, you can see at the superior limbal over the right and the left eye, there's prominent gelatinous limbal thickening. This is as a result of a chronic allergic or inflammatory response, which leads to conjunctival tissue edema and inflammatory cells infiltration and accumulation. And there's conjunctival hyperemia. Okay, next, we focus on the right eye, where you can see that there's epithelial defect at the paracentral cornea, which measured around 3 × 2 millimeter with opacified base, roll edges, and there's no infiltrate seen. And this feature is suggestive of the grade 2 shield ulcer. So this photo is, you can see at the top, this is the fluorescent staining of a normal eye. And this is the patient's eye. You can see that the stain picked up by the corneal epithelium basement membrane, and which demarcate the devoid epithelium area of the cornea. And there's also generalized punctate epithelial erosion. You can see these small green dots which is the microabrasion. And the area of epithelial defect, which is stained by fluorescent sodium and appear bright green when viewed using blue cobalt filter. So this is the description of the examination finding. The intraocular pressure of bilateral eye is normal, 16. With the open lid innervation, we can see giant cobblestone papillae with ropey mucus discharge bilaterally. Conjunctiva is generally injected bilaterally with pigmented changes, and there's gelatinous limbal thickening 360 degrees. And there's also transverse dots. However, we can't really see over in the photos. And in the cornea for the right eye, there's epithelial defect, paracentral 7 o'clock measuring 3 times 2 millimeter with opacified base, roll-up edges, and there's no infiltrates. And other examination is unremarkable. So we move on to systemic physical examination. You can see that there's skin excoriation marks around the neck and also there's elbow flexor. And there's also nasal salute signs. And our provisional diagnosis is bilateral eye vernal keratoconjunctivitis or VKC with right eye shield ulcer, with additional diagnosis of atopy, which is atopic dermatitis, allergic rhinitis, and bronchial asthma. So for the investigation, we did send a right eye swab culture and sensitivity, which grows Staphylococcus aureus, that's sensitive to chloramphenicol and fusidic acid. We did also send a patient for skin prick allergic test, which came back positive for house dust mite, prawn, crab, and also rice, and also dust mite, house mites, and also storage mites. So we get to the final diagnosis, which is bilateral eye active VKC with right eye grade 2 infective shield ulcer. And the patient was started on both eye, got dexamethasone 2 hourly, which is the steroid. For the right eye, we started on antibiotic moxifloxacin, also intensively 2 hourly. Both eye got olopatadine, both eye got cyclosporin 0.5%, and also copious amount of artificial tears. And we referred the case to pediatric team, dermatology team, and also ENT team for optimization of the underlying bronchial asthma, eczema, and also allergic rhinitis. And the patient also was subjected to bilateral eye supratarsal triamcinolone acetonide injection with right eye superficial correctectomy under general anesthesia. So after the intervention, you can see that after 6 months, the tarsal conjunctiva is relatively smooth with a clear and pristine cornea and also white conjunctiva. This is the photo just for comparison. On presentation, you can see, and after the intervention, around 6 months, the visual acuity came 6/9, which is very good. And you can see that the tarsal conjunctiva become more smooth, and you can't really see the cobblestone appearance anymore. And this is for the right eye, and this is the left eye. So that is all for the case presentation. I open the floor for any questions. If there's no question, I will pass my presentation to next panelist. The first panelist, which is Prof. Adawiyah. Oh, sorry, Prof. Aneeza. I welcome Prof. Aneeza to the stage for her speech. Thank you, everyone.
Okay, Assalamualaikum and good morning. I'd like to thank the ophthalmology team. I see Prof. Haslina is also here. Okay, now I'm nervous. For inviting the ENT team here today. So this child was referred to us for further management of the allergic rhinitis. So I'm going to go through a very simple history. He's a 13-year-old, just a child, and the presenting symptoms for the ENT part is that he has intermittent nose block, runny nose, itchy nose, which has been for the past 1 year. Okay, and he also has this what we call atopic triad. On top of the vernal keratoconjunctivitis, he has allergic rhinitis, bronchial asthma, and eczema. So if you have VKC or allergic rhinitis, there's about 20 to 30% chance of you also having eczema and bronchial asthma. But if you're seeing the child the other way around, if you're seeing a child with bronchial asthma, then it's higher. It's about almost 70% that they might have all these other diseases, especially allergic rhinitis. So it's very important for us to have a look at all these diseases together and get the control of the symptoms. Okay, so the main thing about this child is that his nasal symptoms are triggered upon exposure to dust mite. So he says that whenever he's around dusty areas, he's going to get triggered. And it's also triggered by cold weather, such as aircon. Chronic rhinosinusitis, so he did not have any reduced smell, facial pain, or discolored discharge, and this is not very common in children. You should also look at the ear symptoms. So the relevant negatives here are, you are looking for evidence of eustachian tube dysfunction, which is common among children with allergic rhinitis, and the symptoms of eustachian tube dysfunction are ear fullness, you feel like you tengah turun kapal terbang, tinnitus, and when you swallow, you have this popping sensation, and in more severe cases, they have ear pain and reduced hearing. And this is what leads to middle ear effusion in the long run if you don't treat the underlying allergic rhinitis. Okay? So on physical examination, this child exhibited all the classic signs of allergic rhinitis. So he has allergic shyness. Do you know what that is? It's basically what you guys have most of the time, but it's not supposed to be in children. He has dark circles under his eyes. Okay, it's because when you have inflamed nasal cavity, a lot of the blood supply goes to your nose, so it leads to reduced blood supply around your periorbital area, so you have like dark circles. Yeah? They look tired. They have allergic salute, so they'll be rubbing their nose, but in a unique way, they will be rubbing it upwards. Okay, and this leads to a crease at the top of your nose. Okay? Apart from that, his mouth breathing. And long-term mouth breathing leads to adenoid faces. So he'll have like a loss of malar prominence here, and the face will be elongated. So they'll basically be looking at you like this, and the face looks elongated. And over the long run, this puts them at risk of developing obstructive sleep apnea when they are older. And on top of that, he has a hyponasal speech. Do you know what's hyponasal speech? It's like a stuffy nose. Hypernasal is when you're talking, the air is coming out of your nose. That's hypernasal speech. So allergic rhinitis, because of the blocked nose or adenoid hypertrophy, the speech becomes hyponasal. Okay? So that tells you that he has a severe blocked nose. Now, when we did examination, we did a cold spatula test. There is a reduced misting on the right side, and this improved with Cottel's maneuver, indicating that the obstruction is more anterior. So it's more likely at the level of the nasal septum or inferior turbinate. And on anterior rhinoscopy, we found that indeed there is an anterior deviated nasal septum and there is hypertrophy of the inferior turbinate, such as in that picture. You can see that there is like gelatinous mucosa over the inferior turbinate. So we proceeded with the nasal endoscopy because this child is old enough to have one. So you can see here that this here is the, oh, you can't see my pointer. On the left is okay, we're going to go to the left. This is the left nose. That's the septum on the left. On the right side is the inferior turbinate. We're going down on the floor of the nasal cavity, and you can see that there's a lot of secretions and there's a lot of jelly. So all this indicates like inflamed mucosa. So now we're trying to pass through the floor of the nasal cavity into the nasopharynx, and you can see that that's the nasopharynx. There's no adenoids there, and on the right side, you can see the eustachian tube opening. So you can see that relation. So everything looks inflamed, and this will cause a eustachian tube dysfunction if you don't treat that underlying inflammation. Okay. So for this kind of presentation, there's usually 3 differential diagnoses. It's either allergic rhinitis, non-allergic rhinitis, or chronic rhinosinusitis. But for this child, the most likely diagnosis is allergic rhinitis because he's young. Okay, he has asthma and eczema as well. His symptoms are triggered by dust, and there are no symptoms to suggest of chronic rhinosinusitis. And on your scope, you have already ruled out presence of polyps or edema coming from the osteomeatal complex. So it's most likely allergic rhinitis. Okay, so to confirm allergic rhinitis, we did a skin prick test for him, and this is his result. So it looks a bit crowded there, but anything more than 3 millimeters in the wheel diameter, you will put an allergen on the arm and you will see an urticaria sort of like lesion come up, and you will measure that. So anything more than 3 millimeters is considered positive. So he's got a few things positive here. And Notebook LLM did this for me. And we look at the aeroallergens. That means the allergens that you breathe in. The dust mites. DP and DF are two different species of dust mite, and they have the biggest wheel. So about 11 millimeter, 16 millimeter. This is really big, and it is clinically relevant. So given that he also has symptoms of rhinitis, plus a positive test towards dust mite, it is most likely that this confirms an IgE-mediated mechanism in this child. So this child has allergic rhinitis confirmed by your skin prick test. But what about the food? The crab, the prawn, and the rice. So Dr. Nabil presented earlier that the child said whenever he eats prawn, he'll get a rash. So that is also relevant, and the management would be avoidance of the crab and the prawn for this child to reduce his symptoms. But what about rice? Do you tell them? No more rice for you. Okay, so this is where you must remember that a skin prick test alone does not diagnose allergy. Okay, skin prick test plus symptoms equals to allergy, like the dust mite and the allergic rhinitis symptoms, that's allergy. But rice, rice, but I can eat rice. That is not allergy. That is just what we call irrelevant sensitization, or the child has probably developed tolerance over the years. So it is important that you don't withhold the rice from the child. He should keep on eating rice. And that's why for food allergy, it's something different. You only test for whatever the child complains for food allergy. You shouldn't do a panel, but because we don't want to do things many times, we tend to do a panel. But when you are interpreting, you should always correlate it clinically. Okay? No unnecessary withholding of food to a children, please. You are going to compromise their nutritional status. Okay, I hope we get that across. Now, for the management of allergic rhinitis is always this pyramid. First, allergen avoidance. It's very hard to avoid dust mite, but the least that you can do is tell them to change their bedding regularly, remove sources of dust mite, such as carpets and soft toys in their rooms. Okay, but the main treatment would be pharmacotherapy. And we always go to intranasal corticosteroids, mainly Nasonex. We have Elonite here. It's also a form of Nasonex, just a different brand. But if that doesn't work, you can do a combination, Nasonex plus intranasal antihistamines, which is Dimista. Okay? And Dimista you can give to children above 6, Dimista is above 12, while Nasonex is for children above 2 years old. Okay? Even young kids can take it. And of course, you give oral antihistamines only as needed. You're not supposed to take it daily because it causes a lot of dryness, and that's not good for his eyes and for his skin as well. So the mainstay should be intranasal corticosteroid daily and oral antihistamine only if there is breakthrough symptoms. Now, this child responded well to the pharmacotherapy, but should he not respond well, there is an option of escalating the treatment to immunotherapy. So what is immunotherapy? Okay, we have here Acarizax. It's a sublingual version. There's also the injection version, but we don't do that here. We only do the sublingual version of immunotherapy. And basically the principles of immunotherapy is that if you are allergic to dust mite, we give you dust mite, okay, in the hopes of inducing tolerance. And at the initiation phase, because you're allergic to dust mite, and I'm giving you dust mite now, this is going to cause more symptoms. Okay, it's going to induce a lot more symptoms at the initial phase. And so if you have asthma and eczema, it's probably going to get worse. Your allergic rhinitis is going to get worse in the first 3 months. But over repeated exposure, you keep giving immunotherapy, either as injection or sublingual, this is going to start inducing IgG4 antibodies. Okay, and these antibodies are actually good antibodies because it doesn't degranulate the mast cells. So this is how you develop tolerance. And over time, these IgG4 antibodies is going to compete with your IgEs so that you then over time become stable. It is sort of like a cure. So if you're only allergic to dust mite and you're taking dust mite immunotherapy, you can actually reduce your dependence on the medication, and it can give you protection for up to 10 years if you take it for over 5 years. But what's the problem? Why haven't we offered it to this child? Okay, the Acarizax is FDA approved. It can be done for the PDF, which he is allergic to, but the cost is an issue. So his parents are not government workers. It costs 450 ringgit a month, and you have to take it for at least 1 year. So it's a lot of financial burden. Okay, but say he can. Say the parents say, okay, we have a lot of savings and you want to start immunotherapy. You still need to consider his other comorbidities. Like his asthma is controlled, but you should check if his FEV1 is less than 70% and make sure that there are no exacerbations in the past 3 months. Because again, remember, when you are starting immunotherapy, you might be exacerbating the symptoms. Okay, and also regarding his eczema, check his eczema. If it's mild, you can start it. But if it's moderate to severe, you should control that first, because eczema is really something that is bothersome to the patient. It can get really bad when you initiate immunotherapy. And it may also worsen his conjunctival symptoms. Okay, so that's something that you need to consider. And if you want to start immunotherapy for this child, we need to have a discussion with the ophthalmologist, the respi physician, and also dermatologist, because at the first 3 months, we're going to make it worse. So they're not going to be very happy with this if you start and then refer to them, can you help me control it? We should discuss with them from the start and work together as a team. Okay, so in conclusion, this patient has asthma, eczema, and then this is proven by your skin prick test. So the treatment strategy would be allergen avoidance, nasal steroids, pharmacotherapy, and consider sublingual immunotherapy to induce long-term tolerance. And the aim of it would be you need to get symptom control and achieve overall reduced disease burden for this child. Okay, with that, thank you. Okay, so I guess I will pass on the next talk to Dr. Prof. Adawiyah from the dermatology department, and she will talk about his eczema. Dia kena gelap kan tu ni? Mouse is not moving. Hit dia.
Assalamualaikum and a very good morning, everyone. That was a very excellent talk by Prof. Aneeza. I don't think I can top that, but I'll do my best. Okay, I'm going to cover the atopic dermatitis bit of it. Okay, a little bit about atopy. Just now, Prof. Aneeza talked about the atopy triad, but in dermatology, we talk about the atopy march. So you see, that's why we all should sit together, because sometimes we use different terms to basically describe the same things. Okay, so in the atopy march, the atopy march usually describe just the primary clinical manifestations of atopy. That would be eczema, food allergy, asthma, and also allergic rhinitis. So if you remember this patient just now, the order that he developed all these diseases are actually just like the chart. Except like allergic conjunctivitis is another clinical spectrum of atopy. So there's no really place where allergic conjunctivitis is on the chart. Okay, so in terms of the skin eczema and also the eyes, when we diagnose eczema, we sometimes follow the Hannafin and Rajka diagnostic criteria for atopic dermatitis. There are a few diagnostic criteria. This is one of it. So there are 23 minor criteria, and some of them are actually eye-related. And for example, recurrent conjunctivitis, that would be allergic conjunctivitis, the Danny-Morgan intraorbital fold, keratoconus, anterior subcapsular cataracts, and also orbital darkening. So just now, Prof. Aneeza, I think mentioned also is the orbital darkening, but she called it the allergic shiner. Yes, allergic shiner. So I think they are basically the same thing. Okay, and they would also have immediate type 1 skin test reactivity like this patient had. serum IgE was not performed for him. Okay, so this is how a patient with eczema would, the faces of a patient with eczema. What I wanted to show is actually the Danny De Morgan fold, which you can see on the top left photo. The lower eyelids, they are creases. So that's the Danny De Morgan fold. The patient on the right top also has it, but it's not very clear. It's more clear on his right. Okay, and the two bottom pictures are trying to show the periorbital darkening. It's not very clear in photos. Usually it has to be seen physically. Just like eczema doesn't come out really well in photos, so you have to really see the patient yourself. Okay, so that's two clinical signs that can help us to diagnose atopic eczema. And if you notice, the noses, okay, I did not cover the photos because I need to show both the patient's eyes and also the mouth. Because in the distribution of atopic dermatitis on the face, the rash tends to go over periorbital and also perioral. In severe cases, they affect the forehead and also the cheeks. But the nose tends to be spared. So if you notice, all these 4 patients, the nose are not affected. The nose, the normal skin is the nose. Okay, right? So this is atopic dermatitis on the face, like I mentioned just now. And how do we describe the rash? They are basically patches. Erythema, depending on whether the inflammation process is active or not. So if there is no or little inflammation, there will be minimal erythema or no erythema at all. But the skin is always dry. They will feel rough, and then we see erosions. Like the boy in the yellow shirt, or both of them are in the yellow shirt. Okay, this side, there are a lot of erosions. The erosions can be spontaneous, or it is because they are scratching. And again, you can see the nose is bad, and then periorbital is affected, perioral as well. And in both these patients, the eczema was severe, so they had both the forehead and the cheeks affected. Sometimes it's just on the cheeks, and they can be mistaken for malar rash, and people will send autoimmune screening. This is the distribution of the rash according to age. When they are less than 1 year old, the rash can occur anywhere, but it tends to spare the diaper area. This is called infantile eczema. They are not yet called atopic eczema, but soon, once they are older, then the rash will become more on the limbs and will have a predilection for the flexural areas, the neck, and also the periorbital areas. Okay, so back to our patient. Our patient currently is under follow-up with GP, and as Dr. Nabil mentioned just now, he is using aqueous cream PRN. He defaulted our dermatology follow-up, and he's been given another referral, but yes, we have not seen him yet. So let's look at the picture of his cubital fossa. So what you can see is, you can see the lines, sort of if you imagine when you're older, you get wrinkles, but these wrinkles are not just localized and is affecting a young child. So when you see an accentuation of your natural skin lines, this is called lichenification. If you palpate it, it feels thickened compared to normal skin. And then you can see erosions, the reddish area, or hyperpigmentation. Most patients develop post-inflammatory hyperpigmentation. That's why everything becomes brown. Some patients think that, oh, I applied topical steroid and my skin becomes brown. Okay, so the skin becomes brown is not pathological. It means the treatment is working, and they think that it becomes brown, the treatment is bad. Okay, so just try to make that clear if you see any of patients. We don't have any other photos for these patients, but he is using aqueous cream PRN, which is not correct. In general, everyone with eczema has dry skin all over. So the first management of eczema is topical therapy. Other than topical therapy, bathing is also very important. They have to use mild soap. Water should not be too hot or too cold, and they should not bathe for too long. Okay, so that's the rule for bathing. Then they must apply moisturizer, and moisturizer is regularly every day, not PRN. Moisturizer is important because it reduces the number of flares and also the severity of each flares. These are the list of moisturizers which is available in our hospital, except for others. Okay, we don't have those classified under others. We have aqueous cream, that aqueous mixed with glycerin, either 25 or 50%, emulsificant ointment, and also white soft paraffin. Of course, the mainstay of therapy for eczema is topical corticosteroid. Not all steroids are the same. They are divided into potencies, mild potency, moderate potent, and also super potent. So the choice depends on the age of the patient, where we want to apply the topical steroid, and how long we want to apply it to. Obviously, for eczema, which affects the eyelids, we are very concerned about using topical steroids on the eyelids because it can cause absorption and causes development of increased intraocular pressure, glaucoma, and also cataracts in the long term. So for the eyelids and periorbital area, use only the mild potency corticosteroid, and even then not for too long. Try not to exceed 2 weeks or maximum of 6 weeks. Okay, so nowadays there is a lot of steroid phobia. Patients does not want to use steroid at all, topical steroid, oral steroid, injectable steroid, all sorts of steroids. So we have the non-steroid options for management of eczema, which is what we use for people with periorbital involvement. So we have the calcineurin inhibitors, which are tacrolimus and pimecrolimus, also known as Elidel and Protopic, and also the PDE4 inhibitor, which is crisaborole. There are other options for treatment which is not available in this country. The limitation of the non-steroidal options are because they cause it's stinging. So most patients refuse to use it. Okay, they refuse to use steroid. We give them non-steroid and then they can't use it because it stings, and it can sting very badly until they can tear up. Right, okay, so the non-steroid options can be used all over, doesn't matter where, it's just that the limitation is cost. Because for calcineurin inhibitors, for example, tacrolimus, a 30-gram tube can cost about 150, while pimecrolimus would cost 80. That's just, that's a bit expensive because it's a little, and patients with eczema need to use a lot. Okay, physical therapy is phototherapy, which either narrowband UVB or PUVA, but PUVA is not used a lot nowadays. But physical therapy for phototherapy is difficult for the patient because the patient has to come to the hospital for the therapy twice a week for a minimum of 3 months. So that's difficult for people who go, for students who go to school, and also for people who are working. Systemic treatments include azathioprine, methotrexate, cyclosporine, upadacitinib, abrocitinib, which are the JAK inhibitors, and dupilumab, which is an anti-IL-4 and 13. Okay, so if you read the recent guidelines for atopic dermatitis, basically azathioprine, methotrexate are not recommended anymore because of its systemic side effects. And because of the availability of safer, newer medications. Cyclosporine is still recommended, but not for prolonged period. We can only give cyclosporine for a maximum of 1 year, 6 months to 1 year. This is all because of, to limit the side effects of these drugs. However, for the JAK inhibitors and also dupilumab, again, our limitation is cost. You want to know the cost? The JAK inhibitors would cost about 2,500 per month. And dupilumab would cost about the same as well. But dupilumab is injectable. There are also newer treatment which is still not available in the country, like Nemo and also lebrikizumab, which is coming soon. Okay, that's all. Thank you very much. And I would like to invite Prof. Wan Haslina to wrap up the session and also tell us more about VKC.
Bismillahirrahmanirrahim. Assalamualaikum and very good morning as well to everybody. Thank you, Prof. Aneeza and Prof. Madya for the exciting and very fruitful discussion about the allergic rhinitis and atopic dermatitis. So I'm sorry, I adapted this lecture that I had when I presented in Ocular Surface Disease Seminar in last year. So just to recapitulate back about the things that we have discussed, we are looking at a patient with vernal keratoconjunctivitis, and in this case, patient is quite refractory, and there's medical. I'm going to discuss about medical management, surgical management, what are the emerging therapies, and what are the take-home messages. So, for your information, vernal keratoconjunctivitis condition is commonly bilateral. It is rarely appears in ages of less than 3 or more than 25. So the age ranges during development of a child. So male has more incidence compared to female, and usually this condition lasts for years up to the patient reach puberty or up to the early age of 20s. And the thing about this condition is eventually it will burn out. I mean, eventually it will go away. I mean, or a patient develops sensitivity, desensitization of things. That makes the eye conditions much more, how would I say, bearable. But before that, there are certain things that we need to make sure to ensure that this patient doesn't end up with blindness or blurring of or loss of vision. So you must understand that VKC is associated with type 1 and type 4 hypersensitivity. Type 1 hypersensitivity involves IgE-mediated hypersensitivity. So the typical manifestation of type 1 would be anaphylaxis. However, localized anaphylaxis can also be experienced. For example, in this case, patient have a severe allergic keratoconjunctivitis. And in some, it also involves cell-mediated hypersensitivity, where you have T helper cells being sensitized and cause a significant myriad of reactions towards activating cellular damage. So what about VKC that is so important here? Why did I choose VKC for our presentation today? So usually CPCs are more like a drama. You have like exciting chasing of diagnosis and all. But for this presentation, for this CPC, I chose VKC because it's something that most of us ignored and maybe misdiagnosed, and letting a child go on without a proper treatment can predispose a child to permanent consequence or complications in the future. So as a study done by Devonside, where in 2017 they reported all over the world VKC is affecting about 5 million children, and it is further expected to rise in 2030. So the VKC symptoms that I would like to highlight here is you must understand that most of the time patient will present with severe itchiness of the eyes. Patient will just squirm his eyes when looking at things, and they will avoid activities that makes them have to see far or have to focus on some things. So what they will do is they will take the mom's phone and just stare at it for a long time because they can't really see in front of the TV. So if they watch TVs, they will need a certain near distance for them to see well. Because if they see at a distance, they will not be able to focus. So, and most of the time, the presentation is delayed to the ophthalmologist because the patient usually does not complain. okay, or they just simply avoid any activities that actually force them to see. So when they come to us, sometimes it is quite late. For example, in this patient, he already developed shield ulcer, which actually affects his vision. So as a 13 years old, he knows how to complain. But if it's a 7 or 6 years old, they just don't want to do anything about it. They'll just keep in a corner, ask for the phone from the mom, and just squirm the eye under a dim light. So tearing, musculoskeletal, photophobia, pain, blepharospasm, and decreased visual acuity. And this is the thing that we don't want, where the patient develops scarring on the cornea. So VKC signs, there are many. All of these same signs can be seen under slit lamp examination. But certain things you can also see with just using a pen torch. So let me go through one by one. What are the things that we are looking for? So when you can see VKC involve the cornea, this is where the blurring of vision happens. So where there is superficial punctate keratopathy and the dusting of the corneal surface, this is where it started first at the upper 1/3 of the cornea, and then eventually involved the whole cornea area. And there was pannus formation, filamentary keratitis, shield ulcer, as what was described by Dr. Nabil initially. And the thing that we don't want is when it goes severe weakening of the cornea and then cause further coning of the cornea, which is called keratoconus. So keratoconus is another diagnosis that is actually important for us to not go into this, because it also potentially blinding. Okay, so when you have, as I said, when you have VKC with cornea involvement, that's when the blurring or loss of vision happens. So what are the things that we look for when you have a patient with VKC? You invert the eyelid. This is something that is very, very important, because it will show us the severity of the condition other than the surface that we saw just now. So there are this typical description of cobblestone papillae, and as you can see here, there's also associated ropey discharge. So mostly because the presentation is mostly on the upper eyelid, so most of the corneal complication happens above the middle line of the cornea, which is on the upper part of the cornea. So this is another patient, a picture of patient who have mucus discharge, mucus ropey discharge, and you can see the surface is not as smooth. There's actually an ulcer here, and there's actually micro abrasions happening all over the cornea. And this is when patient come to you with, "Mak, saya tak nampak," ataupun "Cikgu, saya tak nampak." But as I said just now, small kids will not complain. Okay, so this is the staining that was described initially, where you can have micro staining of the cornea, which indicates loss of epithelial cells happening in a chronic inflammatory condition of the eye. This is the Trantas dot. Okay, what Trantas dots are actually eosinophils collection at the limbal margin of the eye. So you can see cells collecting and actually deposited at the corneal surface, and also this gelatinous changes at the limbal margin as how our patient presented. A shield ulcer is something happening as well. What does it mean by shield? Shield means something is trying to protect. Okay, so what does shield do? It is the first thing that was attacked by anything externally. So whenever there is cobblestone papillae, the first thing that's going to be attacked is the cornea, and that's why the term the shield ulcer comes from. In this patient, another patient, there is actually pannus formation. So pannus is actually a fibrovascular complex that sits under the epithelium and cause bleeding or scarring. So this myriad of presentation happening on the patient's eye can be unnoticed if you don't see it properly under slit lamp. So this is a severe form of gelatinous changes. And when you see this patient coming to you, a child coming to you with rubbing and all, there is something that you need to look for, because clinically, most likely the patient is having a bundle keratoconjunctivitis. Laboratory-wise, in the literature, they describe checking for a specific IgE in the serum and tears, in which we don't do in our hospital, or FBC for eosinophilia, that one we do. Conjunctival scraping and tear cytology, also we do not have that means of investigation or tear strut test level. So, but we do have our colleague, which is our biclinical, we diagnose it, but we also have our colleague, which is our ENT and our dermatologist to help us with the other form of diagnosis and therapy. So in refractory VKC, if this is non-responsive to therapy for more than 2 weeks and persistent of symptoms and signs, a very slow improvement of signs, we straight away go for a more intensive therapy. Why? Because this therapy is tailored to patient condition and also corneal involvement. Our main aim when we treat VKC is to give them quality of life as well as to prevent corneal complication. So what corneal complication? And as mentioned just now, anything that can cause corneal involvement or scarring will be very pertinent to patients' future, because these are children. When they grow up, if they have poor vision, they can't be an ophthalmologist, they can't be a pilot because of this poor vision. So identify allergen and prevention is something that is pertinent in managing any VKC, in which that we have discussed about the history, skin prick test or blood allergy tests, and avoidance of exposure to allergens. As what Prof. Aneeza said just now, rice, if it's not really discussed just now, that you don't really need to let the patient not eat rice, but maybe adjust it to somehow, I don't know, reduce amount. Would it help, reduce amount? Makan je, yeah, okay. So those are the things that should be advised to patients. And I mentioned also identifying and removal of cause, especially if it's involving house dust mites. We can't avoid house dust mites altogether, but at least we can actually reduce the exposure to the patient by making sure there are no carpets around. Patient has changed the bed sheets every 2 or 3 days, and make sure that you don't have pets around, so that these are the things that can cause problems. The control of atopy means control of other myriad of allergic conditions, such as allergic rhinitis, sinusitis, asthma, and eczema. So usually when a patient comes to me with VKC symptoms and signs, that is one of the first things that I would do, ensuring the patient has proper care in terms of other atopic condition. So management will be anti-allergy and mast cell stabilizers. So try and avoid as much as possible preservative medication, because eventually patient may develop allergic to preservatives eye drops. So topical mast cell stabilizers are given, which is also preservative-free tears substitute, topical antihistamine and mast cell stabilizer, as well as maybe montelukast and oral histamine initially, maybe for the first 1 week to 10 days of the initial presentation, would control the other allergies. So, but in this patient, we give them something more than steroid. So remember, topical steroid in VKC is served as a rescue therapy. It is not the mainstay of therapy. Remember that. So with this, you have to give them intensive medication initially, and it should not be more than 6 to 8 weeks. Okay. The moment you think that you need to give the patient more than 1 month or 6 weeks, you have to start the patient on something more else, which is steroid sparing, such as cyclosporine. So we have topical cyclosporine of 0.5% 4 times a day, in which this is literature has shown to be very effective in controlling VKC. Other than that, patient can be given ointment tacrolimus, 0.3%. This is an ocular preparation, but make sure that this patient doesn't have any history of HSV keratitis. So all of these can be given at the same time, but topical steroid should be tapered off after 2 to 6 to 8 weeks, whereas the others can be tapered off after 6 months of control. So the targeted surgical therapies can also be done, for example, if this patient have shield ulcer. So in this patient, what we did was not only we give them all the medication therapy, referral to the our colleague for control of the atopic conditions, we also did something called superficial keratectomy with EDTA, in which that another option will be a PTK, which is a phototherapeutic keratectomy, which is not available in our hospital because we don't have corneal refractive or laser machines. So we do this superficial keratectomy with EDTA. And for the giant cobblestone papillae that patient have, we did a local supratarsal steroid injection. TA is triamcinolone acetonide. Okay, triamcinolone acetonide is given up to 0.6 ml injection, and we sometimes, if it's very severe, do this graft excision, which for me not need to be done because commonly the supratarsal steroid would really help already. So this is a video showing how we do supratarsal injection. So intraoperatively, it has to be done under general anesthesia because this is very, very painful if it's done under local anesthesia. So we initially invert the eyelids, identifying which one is the tarsal plate. So after we know which is the tarsal plate, we have to avoid the area immediately after the tarsal, the superior tarsal margin, because that is actually where vessels lying, which is the superior arcade vessels, runs. So we don't want to cause any form of ischemia to make sure that a patient doesn't develop complications later. So after identifying which area is supratarsal, which area is the superior conjunctiva, we then do the injection with the triamcinolone acetonide. So this injection can be done once. Okay, this is where I measure the area above the supratarsal plate and ensuring that the area exposed is adequate for me to avoid the arcade vessels. So above that, okay, then I will just introduce the needle and then go on along the area that avoids the superior arcade vessels and then start to inject the triamcinolone. So making sure that the patient receive at least 0.4 up to 0.6 milliliter of triamcinolone acetonide. TA is very good because it is actually in crystalline form. So it stays in the eye longer. One of the things that we must make sure that this patient doesn't have history of steroid responsive ocular hypertension. One of the things that you must know when you start patient on steroid is you must make sure that you follow this patient up, because patient may develop secondary ocular hypertension, and if it's very severe and non-treated, they can actually go towards steroid-induced glaucoma. So other than all the treatment that we gave, all the surgical intervention that we do, we must also make sure that we treat the vision. So after, for example, in this patient, after we did everything, there is still some minimal scarring. And when we do refractive assessment, if there is refractive error, you still can give them glasses because they may develop astigmatism later. And as I mentioned just now, monitor for the problem of keratoconus, which is another diagnosis somehow related to VKC. So the future of allergy eye disease treatment still is not really well established. There are new anti-allergic medication or regime being discussed about, but nothing that is actually still introduced yet in the clinical practice. There are certain parties who are actually looking at stem cell therapy to treat VKC. However, again, there is not yet a proper clinical trial that proves its efficacy or practice, because I think it's still ongoing studies. So we had done one case basis condition where we infused mesenchymal stem cell, and it actually induced a controlled clinical picture for up to 12 months. However, after 12 months, patient come again with a severe VKC conditions. So in a way, it actually able to control up to 1 year, but it needs to be needs to be treated. Retreated. So the challenges in management, remember, atopic related, so you have to control all the other conditions. You have to ensure compliance. And again, at the end of the day, you want to ensure patient have a good quality of life. So with that, I thank you. So any questions? Just want to tell that we are going to have a Kahoot session a bit, about 5 questions. Those who are able to get the highest mark will be given a token by our side, our department. So stay tuned. And this Kahoot session is only for medical students. So we allow medical students to involve, not the masters though. Okay, let's see. Any questions so far about VKC? Okay, so I hope you benefited from the session. I would first also thank our panelists, Dr. Nabil, Prof. Adawiyah, Prof. Aneeza for the excellent presentation. And thank you very much. So now we are going to start the Kahoot. So the Kahoot questions comes from the lectures that we presented just now, the cases and all the conditions that's related to it. So, yeah, please wait. So, thank you very much to those who attended. Just a bit more for us to open the Kahoot.